Thanks all
And where is Dr. Hassan from?
I'm from Riyadh, Saudi Arabia, King Khalid Eye Specialist Hospital.
King Khalid Eye.
If you don't mind, we can have 1 minute, everyone, to give his introduction about himself. It will be more clear.
Okay.
And maybe, so we'll start with Dr. Dr. Chawla, please start.
I'm Shobhit Chawla. I'm practicing in North India in a most populous state, and we run a major eye hospital here. I have 12 consultants working with me, out of which 6 are vitreoretinal, and the rest look after other subspecialties. And I'm presently the president of the Vitreoretinal Society.
Thanks for being with us, Dr. Shobhit, for that. Which part of India you didn't mention the state?
Lucknow, Uttar Pradesh. It's right on just near the foothills of the Himalayas. We are about 6 hours from the foothills of the Himalayas.
Okay. So it is very cold now with you?
No, not at all.
No.
It's lovely, pleasant weather.
Good.
Tomorrow it's going to be.
Okay, Dr. Afji, please. Ramzi.
Yeah, I left university almost 10 years ago, and now I work full privately in a private eye hospital. I'm also founder of the hospital. We have 12 consultants, and 5 of them are related with the retina, and the rest of them are the other departments. So, and this hospital is in the city of Bursa in Turkey. It's very close to Istanbul. It's another big city in Turkey. It's about 4 million people lives. So that's all.
Thank you, Dr. Ramzi Boy, for being with us. And so you are familiar with us now, long time with being with us. Dr. Big Boss Carlos.
Big boss. I am not the boss. I'm working in Barcelona. Barcelona is known because of Messi problems and the Barca.
Now, for me, I know Barcelona because you are there. I don't want Messi.
I would say that Dr. Carlos has been one of the legends as far as myopia surgery goes.
Yeah, I think
at least for us in India.
And we are more or less 20 consultants of all specialties, and we enjoy Barcelona. The weather is wonderful, and I invited all of you to come there and to see us.
Thank you, Dr. Carlos. Dr. Hassan Al-Dibi, my dear friends, Dr. Hassan.
I'm Hassan Al-Dibi.
The most humble person. Yeah, please.
I'm Hassan Al-Dibi, Senior Academic Consultant, Vitreoretinal and Uveitis from King Khalid Eye Specialist Hospital, and I'm the president of Saudi Retina Group.
Thank you, Dr. Hassan. Thanks a lot for being with us.
Very
Dr.
nice
Hassan, today he is having a lot of sessions with us. Dr. Rashid.
Dr. Rashid, I'm from Muscat. I'm head of Ophthalmology Center. It's a government center, has got all subspecialties, very big center, and also I'm president of Oman Ophthalmic Society. Welcome all, and I will thank Dr. Muhammad Amri for sharing me, although I'm not giving session, but I'm the panel.
It is our honor and pleasure, Dr. Rashid, all the times. Dr. Ahmed.
Thanks a lot, Dr. Muhammad. You gave the introduction for me. Thank you very much. I'm a vitreoretinal consultant. I'm the medical director of Eye Consultant Center in Dubai Healthcare City. We have 6 consultants. I'm covering the retina, and other subspecialties are covered by other consultants. Thank you for introduction, and thanks all for being with us today. It is our pleasure, Dr. Carlos, Dr. Ramzi, Dr. Shabit, Dr. Hassan, Dr. Rashid. It is my personal pleasure, and all of us.
Thank you.
Thank you, Ahmed.
Ahmed, we can start, I think, if you want with do you have the agenda with you, right? Okay.
Not in front of me, if you can.
Okay, if you want me, I will do that. Okay. So our first session, our first talk, within a second.
Approach to retinal membrane surgery by Dr. Abdul.
Yes. So the first talk, it will be by Dr. Actually, no, it's different, Dr. Hassan. Here we are having Dr. Shobit Chawla. He is going to be the first speaker in this session, and he is going to talk about layered ILM flap in interesting spectrum of cases. Dr. Shobit, yes, please.
Yeah. Thank you very much, Dr. Mohammed Amri and the Middle East Ophthalmic Society. I have really been impressed with layered ILM flaps in macular surgeries since I was introduced to the envelope-like flap many years back at the Egyptian meeting by Professor Hassan Mortada. And so, as we all know, the ILM of the retina is a periodic as fast positive membrane structure, 1.2 micron in thickness, derived from Macular glial cells. These glial cells regulate retinal homeostasis and functionality. However, they also constitute a scaffold for the correct positioning of all neural cells, with a particular importance in maintaining the shape of the fovea. We would be incorrect to consider ILM a single plane membrane. The varying nature of ILM-ERM complex is explained by this. Actually, the interdilating Macular cell end feet have deep extensions from the foot plate to the ganglion cell layer, and that gives it a dimension of both activity and traction. The shear stress generated by the movement of liquefied vitreous on abnormal vitreomacular adherence triggers specific natural inflammatory reactions. The expression of contractile proteins by these cells transforms Macular cells into microfibroblasts, and you get these bizarre presentations, which are fibrosed ILM, ERM, it could be lamellar macular hole, epimacular proliferation, it could be anything. Look at this bizarre presentation with multiple pathologies, and one simple, nice ILM peel fixes it all. So the inverted flap came up initially, and it was met with good success, good applause, with a lot of surgeons switching to inverted flap for large idiopathic full thickness macular holes and myopic macular holes. It seems to be more effective than complete ILM peeling in cases of myopic macular hole with retinal detachment. The pathology being that the inverted ILM contains Macular cell fragments which induce glial proliferation, filling the macular hole and supporting macular hole closure. It may also work as a scaffold for tissue proliferation, creating a microenvironment that encourages correct photoreceptor positioning, and finally improving post-operative anatomical and functional outcome. The hypothesis is in agreement with histopathological findings suggesting a basement membrane is required for cell proliferation. Because ILM is a basement membrane, it allows glial cell proliferation and large macular holes fill with tissue over time. So initially it came to improve the closure rate of large macular holes sizes larger than 400 microns, the inverted technique, and we could easily see it in our post-operative OCTs. We went further into layered flaps. Now, for me, layered flap not only gives us the advantage of an inverted flap, but also fortifies the weak cystic fovea, which is there in many diseases of the macula. So, on nutshell, a foveal sparing layered flap is an effective technique in multiple situations. For example, this acute onset myopic macular hole, and only a young lady, 38-year-old, she had a scarred myopic CNVM in the other eye, with very limited vision. So she came with only 2 days history of this myopic macular hole, and we went acute myopic macular hole, and we went ahead and did this envelope flap technique, a layered flap. And this picture, as I like to use sulfur hexafluoride, this is a picture which is only 4 days post-operative once the gas moved above the fovea. Another situation where I have found layered flaps useful is rhegmatogenous retinal detachments with a coexisting macular hole. After a routine posterior hyaloid removal under perfluorocarbon liquid, we go ahead with the envelope flap technique or the layered flap, and we cover it nicely, and you see that the result is pretty good. And in these combined cases, somehow I feel more comfortable. At times I use oil, at times I use gas. So this patient was with gas, and you have an excellent closure in the post-operative. No, sorry, this patient was a silicone oil, and there's the day one post-operative picture, what you see here. That was the pre-op and the day one. Myopic foveoschisis, which can exist in various configuration, as Professor Matteo will be speaking about that. I don't need to elaborate on the classification. So this is a 38-year-old female. She came with this chief complaint. I put her under watch because I never, unless I don't gauge progressive visual loss, I don't jump into surgery in these cases. She had a traction on the ILM temporal to fovea. I discussed surgery with her. She went back. I talked to her about possible phacoemulsification with vitrectomy, ILM, and C3F8 gas. She decided to wait and returned 1 year later with a visual acuity of 636. So, and this was the configuration. What was noticeable was the traction on the ILM temporal to the fovea. And we went ahead, did a phacoemulsification with vitrectomy, ILM peels, C3F8 gas, and we had a dramatic resolution of the skin. So, a routine surgery with the hyaloid removal. Only thing, by the time I was through with this eye, the very next week she wanted me to operate her other eye for a cataract, and not cataract, a clear lens extraction, and remove her myopic status. She was so satisfied with this. So we make this layered flap. So we are also giving support to the cystic fovea. That is what is my thinking and philosophy in these cases. And then I do an extra peel, not only nasally, but here it was more significant to do in the temporal portion where the real traction on the temporal ILM was. And we release that traction with a large white peel, leaving the flap in place on the fovea. And this is our post-operative result. 1 week, you still see the gas bubble is there. In this patient, I had used 20% SF6. And this is 3 weeks post-op, 6/18 vision, doing well. Another case done in the same manner, phaco-ILM peen and gas for myopic foveoschisis, an only-eyed patient, 20/40 post-op visual acuity. So there is a variability of response to surgery. Combined surgery works better. History of recent progressive decrease in vision is a good prognostic marker for me. And peripheral retina checkup, very important at conclusion. In absence of macular hole, ILM peeling can give good results. For anterior segment surgeons, important to rule out MMT before taking up patients of disproportionate visual loss for this kind of surgery. So another condition where I find there's a large traumatic macular hole. This hole was 12 years old. And as you can see, the patient was very keen for surgery. I decided to give it a try with a layered flap. And we just went around and tucked in flaps from all sides. And we got a decent response. It was a type 2 closure, and it shows the bridging ILM here. And the patient was quite satisfied. He got, from counting finger, he improved to 636 part visual acuity. So this is a patient of optic pit, where initially in these cases, and an additional small coloboma, we used to do non-foveal sparing ILM peel with only a flap on the optic pit of the ILM. And many times we ended up with this complication of a post-operative macular hole. So we modified our technique, and nowadays we do the double flap, where there is a layered flap on top of the two nice flaps on top of the optic pit, and then we do an envelope flap on top of the fovea, and then do an additional peel, which is temporal, because I feel it's very important to relieve the temporal traction also. This was also again an only-eyed patient. He had scarring of the macula with a colobomatous area in the other eye, and he developed fairly good visual acuities, 20/60 post-operative, but it took time. It took nearly 60 days for him to reach this level, and he has been stable now for 18 months. He has only an 18 months follow-up. Another patient, I did this patient. This is an only-eyed young boy, only 10 years old. He came with this coloboma. The other eye was lost with TBR and retinal detachment. And he came with this macular hole at the edge of the coloboma with decrease of vision with a history of only 2 months. I decided I did not want to use PFCL here because I didn't want my perfluorocarbon liquid to go underneath the retina. So I decided to do a layered flap on top. As there was intercalicial fluid, I did some laser photocoagulation onto the edge of the coloboma. Because normally I never do a stuffing, but because it was elevated here from the RPE, I could stuff some edges. And the patient was doing well on post-operative follow-up. I have yet to do the post-op OCT. Thank you very much for your kind attention. Would be happy to participate in any discussion related to it. And any views from Professor Matthew or Professor Aviki or Dr.
Ahmed,
Madan.
please go ahead.
Thanks a lot, Dr. Chawla. It's an excellent presentation and excellent variety of cases for the multiple or the layered ILM flap. I agree with you. It is definitely a great part of our armamentarium nowadays for treating these variety of cases. And you have showed this beautifully. Dr. Muhammad or Dr. Carlos, Dr. Hassan, any comment?
Dr. Chawla, it's really good technique. But I just asked to understand exactly your difference between your technique and standard classic inverted flap technique and also single layer inversions. What's the difference? So as I watch your video, you invert the ILM as a multi-layers over the macular whole area. We call this as a standard inverted flap technique. And the other way that in my practice, I use single layer inverted flap. I pay attention to cover the macular area as a single layer, as a small single layer ILM. What's the difference in your technique comparing this?
I feel the multiple layers fortify the cystic fovea, which is present in a lot of these pathologies. And in the end, I trim it. I go to a cut rate. I go to a suction of 50 or 60 and a 10,000 cut rate, and I trim this, all these flaps. So in the end, they are small flaps which are left. I was introduced to this technique for foveoschisis with by Professor Mortada a long time back, and then we shifted it to a variety of cases. That's the only difference. Otherwise, it's skinning the cat in a lot of different ways.
Okay, another question. So in our case, with single layer inversions, we use brilliant blue stainings in our technique. When we invert the stain surface of ILM over the macular hole area, and we collapse the stain over there for a long period of time. Otherwise, when we peel all the ILMs and we remove the stain, so we observe some signs of toxicity in our case several weeks after successful closure of macular hole, such as RP change like 4 or 5 weeks after surgery, or cystoid change occur in the closed area of the macula. So, and we assume that this is because of the long-term toxicity of the dye can be. And therefore, now we change our technique. We stain as a crescent shape staining of the ILM. We inject like 2,500 micron diameter of PFCl over the macular hole area. We inject beryllium blue, just a temporal crescent shape, keep there like a 30 seconds, then only stain this area and cover the invert the flap over the macular area, but then the inner surface of the flap is not stained. So do you have any such kind of observation in your techniques, signs of toxicities?
I have seen a persistent cyst after hole closure in some of these cases. A persistent cyst, which is a subretinal cyst, not an intraretinal cyst.
Yeah, but persistence is this, but these are new developed. Now, if several weeks after successful closures and we observe perfect macular configuration, vision improve, but several weeks later we observe cystic change on the macular area, and therefore we assume this is a kind of signs of toxicity.
Our contact time is about 10 seconds in a fluid-filled eye. We use BBG, the dark BBG on an average, mostly that, or the one which is fractured in India. And we give a contact time of 10 to 15 seconds in a fluid-filled eye. I don't use it in an air-filled eye. So my contact time is very less. And the technique you suggested, I've been using in my retinal detachments with macular hole, because there I feel my dye will have a tendency to track underneath the retina. So I put a PFCl bubble first, and I stain as a crescent around it. And then I start my peel from there. Have you done multifocal ERG in these cases by any chance?
Not multifocal ERG, but we obtain microperimetry. And also we observe some sensitivity deficiency in that RP change area.
Which type of trypan blue, Dr. Ramsey?
We will modify our technique and decrease the contact time to a larger surface of the retina and start putting PFCl, a small bubble in every case, and just put a drop around it just to help us initiate the peel.
So there was a question, I think, for me.
Yes, Dr. Ramsey. Which type of trypan blue are you using? The BBG or
BBG? Just beryllium blue. BBG. So we know the beryllium blue is safer dye comparing to others, but even with the beryllium blue, so our contact time is about 20-30 seconds. Maybe this is not a long contact time, but when we invert ILM flap, stain surface of the ILM flap over the macular hole area, we keep the dye there for a long period of time, and also it contact with the bare RP on the whole area, and therefore now I change my technique. I do not stain all the ILM surface, only the temporal crescent stain, and to obtain a better and safer results. But this is just observation.
Did you find a difference, I mean, after you use this technique, Dr. Ramsey?
We started this technique, Mohammed, is about 6 months ago. We have like 10 cases. The follow-up period is not so long. We do not observe any complication like that, but we need longer follow-up time and more cases.
Yeah. We would love to collaborate with you on this. It's a very interesting technique.
Dr. Hassan Dibi, Dr. Rashid, if you have questions.
One more question to Dr. Shabit. What's your indications to do this layered ILM? Is it for all your routine cases, or you select?
No. I do it for myopic macular holes. If for a routine macular hole, I do a single temporal flap, which comes onto that thing, but I do a much wider peel around. So it's not only a flap which I do. I'm a little conservative. I like to relieve all the ILM traction around also. But when I have a myopic case or a myopic macular hole in a retinal detachment or a rhegmatogenous retinal detachment with a macular hole, myopic foveoschisis, optic pit, and like this case you saw, rare case of a coloboma in a young child with a large macular hole at the edge of the coloboma. These are definitely my indications. It works well in my hand, so I've been doing it now for quite a few
Rashid?
years.
Dr. Chawla, do you consider the size of the macular holes when you do the
Not in a myopic patient, but now even if I have a acute idiopathic macular hole which is not very large, I like to flap it. Flap has become a basic flap, a single flap has become part of all my whole procedures. I feel more secure with it. I feel it's a more forgiving technique, and the post-operative look is very good in 1 week's time.
And do you do it always with silicone oil or?
No,
gas?
no. My 99% cases are gas.
If
Silicone
there's
rarely used in any macular case in my country.
and if there's a detachment with it, retinal detachment, same time.
If I am very confident, it's not the PVR is not much, I go ahead with C3FA. And if I feel my base excision is excellent and I've done a good ILM peel, I feel confident with C3F8 also. But yes, in my counseling, I do tell the patient that if I feel the need, I might replace your gas with silicone.
Dr.
Ayman?
Yes, yes. Thank you. It's really a very, very interesting technique. My question is, what advantages do you think your technique, which is more close to grafting the hole that have over the single flap, just a single flap? And have you done any electrophysiological tests just to compare the two techniques? Because
no, I haven't.
I'm
wanting to start a series with microperimetry and check how it goes, and even a multifocal ERG in these cases, and see if there is any difference. Because what the concern Dr. Ramsey has raised about toxicity remains in mind also. But my contact time I like to keep very short. 15 seconds, 20 seconds on the outside.
Thank you.
I think that Dr. Chawla, maybe this came out as a technique to prevent the flap from getting dislodged. So if you have multiple flaps that is covering the hole, some of it will be there and continue to be there for a long time. So it will allow the closure and better closure. In my hands, I usually prefer the single flap because I feel that it would be larger and it will cover the whole area. And usually nowadays, I do not extend the ILM peeling because I consider it as a reservoir for maybe later on surgery if it is required.
But I was incited into doing this more from my initial cases of optic pit, where I was doing a non-foveal sparing peel. So in 2 cases, I had macular holes post-operatively. So that incited me to think. I started it with optic pit, then went on to foveoschisis. So 1 flap onto the pit and 3 flaps or 4 flaps, whatever I can manage, small ones onto the cystic fovea, onto the sciatic fovea. So that was what incited me to.
Thank you very much, Dr. Chawla, for this excellent, and thanks for all panelists for interactive actually about these topics. We can go now for the second presentation by Dr. Ayman Midanat. And I think Dr. Ayman, he changed his title of the topic, so we can see the new title with him. Please, Dr. Ayman.
Thank you very much.
Dr. Ayman, you are mute, so please can you unmute yourself?
Now? Yes.
Okay.
Thank you, Dr. Muhammad, for the nice invitation. It's really nice to join such a prestigious panel. And I want just also to welcome our audience tonight. My talk will be about idiopathic lamellar macular hole. Let me see. It's not working. Yeah.
Okay, now. Okay.
Well, the term lamellar macular hole was originally introduced, as you all know, by Gass in 1975, as he reported a case of lamellar macular hole secondary to acystoid macular edema after intracapsular cataract surgery. Whitkin et al. Were the first to define the diagnostic criteria of lamellar macular hole, which is irregular foveal contour, a break in the inner fovea, separation between the inner and outer layers, retinal layers, and absence of full thickness foveal defect with intact photoreceptor layer. Well, but the evolution of OCT and new studies have shown the limitations of Whitkin's criteria, as the lamellar macular hole is not always characterized by an intact photoreceptor layer, often associated with epiretinal membrane and retinal intraretinal cysts. The prevalence of lamellar macular hole in the population ranged from 1.1 to 3.6%, with no significant correlation with gender or age. Well, pathogenesis. After gas theory, more attention has been paid to the role of vitreous in lamellar macular hole formation. Anterior-posterior traction forces on the fovea by the posterior hyaloid due to PVD can cause intraretinal cyst, which deroofing can cause lamellar macular hole. The presence of an operculum confirms this theory. I'm going to show you one of my cases. This is the right eye of this lady. She has this VMT traction. And on the other, the left eye, she has a lamellar macular hole with quite an operculum over it. So we assume that the left eye has undergone the same pathology that's present in the right eye. And this is, I think, goes well with gas theory. The theory of pathogenic membrane mechanism associated with contraction of epiretinal membranes has gained a lot of support as OCT became a standard diagnostic technique. The presence of epiretinal membrane together with an attached posterior hyaloid would cause the formation of lamellar macular hole rather than full thickness macular hole because of the stabilizing effect of the posterior hyaloid on the retinal structures. Splitting between the outer plexiform layer and inner nuclear layer may prevent the dehiscence of the outer layers. The immune histochemical and microscopic studies have shown differences in cell composition of epiretinal membrane associated with lamellar macular hole, identifying two types: the conventional epiretinal membrane and the atypical epiretinal membrane. The conventional epiretinal membrane is commonly found in macular pucker, characterized by hyperreflective line just above the nerve fiber layer, as you see in this case. Commonly associated with traction size as intraretinal cyst and stretching of the intraretinal structures. This is one of our cases of lamellar macular hole. You can see this, the conventional epiretinal membrane. You can see the intraretinal cyst, and you can see the stretching forces on the foveal area. The second type is the atypical or degenerative epiretinal membrane. It's a dense epiretinal proliferation. You can see it here and you can see it over here. And there is no intraretinal cyst in this case. And although both membranes are composed of different cellular structures, they can be of two stages of the same pathological disorder, as some of the epiretinal membrane shows characteristics of both types. Diagnosis: OCT is the gold standard for the diagnosis of lamellar macular hole. It provides measurable and repeatable data on the anatomical damage to the specific retinal structures and allow following the development of the disease. Fundus autofluorescence provides information regarding the integrity of the fovea via analysis of spontaneous tissue fluorescence. Autofluorescence of lipofuscin present in the retinal pigment epithelium will be shown as in this photo. Well, what is the clinical manifestation of lamellar macular hole? Symptoms of lamellar macular hole are often absent or undetectable in the initial stages of the disease, but they usually worsen over time and include decreased visual acuity, metamorphopsia, and perception of central dark spot, the central scotoma. Idiopathic lamellar hole should be differentiated from pseudo holes, as you've seen in diabetic cases, and in other lamellar macular hole secondary to causes like X-linked retinoschisis, age-related macular degeneration, Coats disease, high myopia, trauma, etc. What about the management? Observation is advisable in stable cases with good visual acuity, but the surgical treatment is indicated in patients with progressive vision loss and associated metamorphopsia. The surgery is the vitrectomy, phaco-vitrectomy in most of the cases, small gauge, triamcinolone assisted vitrectomy, dye, peeling of epithelial membrane and ILM, and air tamponade with bending down for 48 hours. I know that some surgeons, they don't use any tamponade. Some they use a longer acting tamponade, but I use only air and bending down for 48 hours. This is one of our cases. I'll show you the surgery. It's straightforward surgery. This is removal of the epiretinal membrane from over the retina. We use, as I said, triamcinolone assisted vitrectomy. I keep part of the triamcinolone in the eye after my surgery, because I feel that it will decrease the inflammation due to manipulation over the retinal cells. I use to leave a part of the triamcinolone in the eye. Well, you can see that the triamcinolone, even it's present in the hole itself. You can clean this with a flute, or you can just leave it. It's not harmful at all to keep it. This is the peeling of the ILM after removal of the epiretinal membrane. We peel also the ILM, and we make sure that we peel a good amount of the ILM around the lamellar macular hole. Well, this is the case that I've shown you. This is pre-op and this is post-op. The patient vision improved. This is another case. This is 0.5 vision, come up to 0.8 vision after surgery. This is another case. This is a very chronic case. In fact, it was a long-standing case. I've done this case, but the vision did not improve at all. And this is a pity. And this is what I'm saying is, when you are planning surgery, do it as soon as possible, because if the patient has progressive loss of vision, most probably they will not improve well after surgery. This is the case that I've shown you. We decided to do surgery on this eye because this eye, the vision, I don't think it will improve much. And this is the eye after surgery. This is before and this is after, and the patient's vision improved. This is another case. In fact, this is an interesting case. This lady came to me March 2016. She has this epiretinal membrane and this intraretinal cyst, which was transformed to a lamellar macular hole June 2016. And the patient, we discussed doing surgery in her right eye, but she refused to do surgery because she has atrophy and bad vision in her left eye. So she was afraid to go ahead and do surgery in her right eye. So we waited. She came back on 2017, 0.4 vision. And in August 2019, she came back with 0.1. She came down from 0.5 to 0.1 in 4 years. Well, she wanted us to do the surgery because she noticed that she's losing vision. So we've done the surgery in June 2020, and this was the result. Afterwards, Unfortunately, the patient's vision did not improve, She was counting fingers before surgery. She's counting finger after surgery. And this, I want to stress the point that if you want to operate, you have to operate early. And I was questioning myself, did I do the right thing by doing surgery on this patient? Because her vision did not improve, although I have a good morphological result, but the functional result was not satisfactory at all. This is another case of 0.6, came back to 1. So the take-home message that there are two different types of epiretinal membrane associated with lamellar macular hole, the conventional and the atypical epiretinal membranes. The lamellar macular hole associated with the atypical epiretinal membrane are more compromised than with the conventional epiretinal membrane, both functionally and morphologically. The lamellar macular hole, although stable initially, it tends to worsen over time, and the knowledge about the pathogenesis of lamellar macular is still partly limited. Standard surgical treatment with peeling of the epiretinal membrane and the ILM yields excellent anatomical and functional results. Thank you very much.
Thank you very much, Dr. Ayman, for this very excellent and comprehensive talk. Dr. Ahmed, mic with you, please.
Thanks a lot, Dr. Ayman. Excellent presentation as usual and excellent surgeries. I agree with you, but my indication for lamellar macular hole is the symptomatic patient. As long as there is a significant drop of vision, that's the time I will intervene. But I agree with you totally. In such cases, you need to clean all the epiretinal membrane, and internal limiting membrane is an essential part of the surgery. ILM peeling, maybe even ILM flap would be even a good option in such cases whenever it is indicated. Dr. Ramsey, Dr. Carlos, if you have any points.
I want to ask you, to everyone, Ayman, first for you, of course, but I want to ask you if you see any difference between lamellar macular holes in emetropic eyes than in myopic eyes, because we observe that in myopic eyes, there is a tendency at the end to promote a full thickness macular hole, while in emetropic eyes is so infrequent. You know, do you see different, you know, in high myopes, you tend to go earlier, because we try to go earlier, trying to avoid a full thickness macular hole in high myopia, because we observe some cases that they evolve to full thickness macular hole in difference to emetropic eyes.
I think Carlos, yes, you're absolutely right, because the mechanism of development of macular holes in myopic eyes is a bit different from the emetropic eyes. So there's a very important role for the sclera, for the retinal vessels, and the sclerotic vessels itself. So they tend to be more difficult to treat that rather than the holes in the emetropic eye. So yes, I agree. If I have a hole in the myopic eye, I will interfere earlier than just to wait, because if you wait, those patients are more likely to progress and to lose vision in the due time.
Another question, Ayman, excuse me,
yes.
A technical question. You know,
yes.
In some cases, when you see the OCT, you see this double layer over the retina around the lamellar macular hole, and this is very difficult to stain. It's very difficult to peel, because you know it's a tissue, it's fluffy tissue. What's the instrument you use to peel this? Do you use the flexible loop? You use Thanos scraper, or you use?
Very good question. In fact, you're absolutely right, because I've shown you this this photo with the epiretinal membrane both sides. This is the atypical type of membrane usually, and as you said, the atypical type of membrane is more difficult to peel, and it's more compromised rather than the conventional type. I use the Eckert forceps only. I don't use any other instrument to peel my ILM. Is just using the Eckert forceps, and of course using the brilliant blue to dye the ILM. You have to be cautious in these cases, because sometimes if you are not cautious, you might convert this lamellar macular hole into full thickness hole if you are not cautious during your ILM peeling.
Can we
I
have
think to answer,
opinion of Dr. Grithar, please? If you have any comment. You are mute, Doctor. Can you unmute yourself first, please?
Now, the last case which you showed, doctor, I feel that even if you had operated early, I don't think the vision will have improved because there was already the photoreceptors were damaged and the outer retinal bands were missing. So I don't think that even if you had operated earlier, there would have been much of vision.
I think if I operated on that patient when we were discussing surgery in 2016,
yeah, 16,
2017, I think that at that time
That's
this patient would have benefited. I don't want to blame myself because she insisted to do the surgery. The patient noticed that she is losing surgery, she's losing vision, and she begged me to do the surgery. I told her now the prognosis will not be as good. She said, I will give it a try.
Dr. Ayman, okay. Can we move to Dr. Ramzi because for the sake of time, Dr. Ramzi, please.
Yeah,
Sorry, Dr. Ayman, to interrupt you.
Thanks, Ayman. It's a great talk. So the first question about the myopic macular hole, it's both for you and for Carlos. So in myopic macular hole, lamellar hole, if the vision is stable and the macular morphology is stable, do you consider to do early treatment in these patients? And the other question, Ayman, in the lamellar macular surgery, is the full thickness macular hole is the most annoying complication of this surgery, in lamellar macular hole. Therefore, I really hesitate to operate this patient. And therefore, maybe ILM flap technique could be a good option for this case, especially in classic epiretinal membrane cases, because it's easy in this patient to relieve the epiretinal membrane and to visualize the ILM, and you can see the clear ILM and emerge over the lamellar macular hole area. I apply this technique in some patients, and it's really it works and it has a good results. What's your opinion about this?
First of all, I totally agree with you, Ramzi, because if the patient has a lamellar macular hole with a stable vision, I would not touch him at all. I would follow him up. I would observe him.
Even in myopic patient, you mean?
Even in myopic, if he has a stable vision, if he has a good vision, I would observe him. But at the moment when he starts to lose vision, when his vision has progressive deterioration, at this stage I would interfere, and I would not wait, because waiting in these cases means that patient will lose vision even if you are going to operate later on. But regarding the flap, the ILM flap, yes, I agree totally with you. In all of my cases that I've done before, I was only peeling the ILM and just putting the air, and I have very good results. Nowadays, with the new technique that we are using for the full thickness macular hole, the single flap, yes, I think it's a very good idea to do it, and I think it's even easier.
And thank you, Dr. Ayman. Thanks, Dr. Ayman, because we are running behind the time. So, Dr. Hassan, if you have any comment or questions, or Dr. Rashid, please, before we move to the...
I would like to add one point, that we have to have all predictors and biomarkers for lamellar macular hole before we do the surgery, and that could guide us to either to go for surgery or not. Myopic patients that prone to have more sequences in the future might be a candidate for surgery, but other type of lamellar macular hole, I will be cautious before going for surgery, unless there is really need for that from the patient side.
Totally agree.
Dr. Rashid?
The only question I have for the panel is, if macular hole in diabetic patient, those they have diabetic change already, on non-diabetics, does it make difference for you on the management point of view?
Well, in diabetic, yes. In diabetic patients, definitely there's a traction membrane, and yes, maybe the mechanism of development of hole is a bit different, but the end result is the same, and I do the same surgery. I go ahead and do phaco-vitrectomy. I peel the traction. I remove the epiretinal membrane, and I do the peel of ILM, and that's it. I put air and I go out. Of course, I have to do laser.
Thank you, Dr. Ayman. Thanks a lot. We can go to Dr. Ahmed. Any comment, please?
No, thanks a lot, Mohammed. I think we are going to Dr. Carlos now
Yes.
for myopic macular hole and foveal schisis.
Thank you very much. I'm going to share my screen now. Okay.
We can mute everyone except Dr. Carlos. So
You see my screen?
yes, we can see.
Okay, perfect. Okay, let's go. I have no commercial personal proprietary interest in nothing. This is some papers have been published about this, and the objective of this presentation is to update of in these kind of topics. Let me tell you one thing. High myopia is defined for eyes with more than 26.5 millimeters of axial length of refractive error, greater than 8 diopters. Some eyes develop posterior staphyloma. How many high myopic eyes with more than 26.5 millimeters develop staphyloma? Let me tell you, half of the eyes. Half of the high myopic eyes will develop posterior staphyloma, and the wide macular staphyloma will be the more frequent. This can lead you to one of these diseases, the macular traction maculopathy, the macular schisis. There are different, pictures of this disease, this entity, progressive schisis. You have inner lamellar macular hole with the schisis, foveal detached or full thickness macular hole with the schisis. Symptoms of this disease, is progressive visual loss. Let me tell you, metamorphopsia, many high myopes show metamorphopsia, but always when a high myope, even if he had schisis, when he has metamorphopsia, always rule out a choroidal neovascularization. They may be very small and very difficult to diagnose. Is this a stable or progressive disease? There are many papers saying that, this entity tends to progress over time. In this paper, 20 over 29 patients, 70% of the patients show progressive disease. This was 3 years follow-up. Look at these 3 myopes. In the left, you can see, when I saw the patient for the first time, 3 years later, 4 years later, or 5 years later, they develop this disease. Then this disease tend to be progressive. What about the prognosis? The prognosis related to the previous visual acuity. Pay attention to the OCT. Look at into the left. In the left, there is a patient that I might show a case very similar to this. The retina is attached. The photoreceptors are attached, but the bridges between the inner retina and outer retina have disappeared. If you operate this patient, no improvement. Look at the second eye, 20 over 400. If you see the external pulse of the retina, you will see this jaggy outer retina. These are the clumps of terminals of the photoreceptors. Visual acuity, I operated this case, and the vision improved 1 line only. The patient didn't, see anything more. Look at the right. This patient has 20/32 with a foveal detachment, breaking the outer retina, but at the end, after the surgery, it ended with 20/20 vision. Look at this, 2 different cases. A worse prognosis in the left because there is a break in the outer retina, better prognosis into the right. 2 important things in this myopic traction maculopathy, peel the ILM and avoid macular hole. Look at this. You have to recognize, for the young people, you have to recognize the difference between the posterior hyaloid elastic, very bad, staining to the internal limiting membrane. This is very rigid, it's like an anterior capsule. The second thing is to avoid a macular hole after vitrectomy. This is very important. How to avoid it? In 2012, 2 groups in Japan described the foveal sparing ILM peeling. Let me show you one case. You can see here foveal detachment, the schisis, and near a macular hole. And then the most important thing after removing the vitreous is to go and peel the ILM. Don't go rush. Don't rush. Slowly. You go to the center and stop. You don't have to cross the foveal area, because if you cross the foveal area, it's more easy to break the roof of the foveal detachment. Look at this, and at the end you ended like this. Some surgeons prefer, I think Dr. Shaula showed a case, trimming the ILM. I'm sorry for that. I use the contrary. I use very low aspiration and very low cutting rate. And you look at, you can see the cutting rate. This is clack, 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 very low aspiration, just to avoid, because if you increase the cutting rate, the tissue tends to go, away from your vititum tip. Look at this. This is another case. I operated the left eye. You can see here with the macro hole in schisis. I did a macular buckle many years ago, but the right eye showed a progressive visual loss. Again, stain. As you will see now, I stain with brilliant blue, as Ramsey and everybody said before. And then I go from the periphery to the center. I don't try to go over the fovea with the peeling of the ILM. Don't try to go rush, just slowly, and then to be sure and leave it like this, and you decrease the risk. I said decrease the risk. Look at this. There are pros and cons. In the literature, you will find papers that say that you don't need it, and papers that say that it's better not to cross. I strongly recommend not to cross. But even if you don't cross the fovea, look at this. This is 3 months ago. This is my case, not my fellow, not my resident. It's my case. I did, sorry for the video because the camera was, I don't know what's the problem. But, I'm peeling, around the fovea. I'm going to the center. I'm cutting, I'm trimming the posterior, the internal limiting membrane, very slow cutting rate, and then very slow aspiration. And I leave this in the center. As you can see here, very slow surgery, no problem. And, at the end, this is a wonderful result. And the patient showed this aspect after the surgery. My question to the panel is, what's your next step? This is 3 months ago. Okay, macro holes, in high myopia, macro holes tend to occur at younger age compared to non-myopics. Always perform OCTs in your high myopes. And some of these patients, they will evolve to retinal detachment. There are 2 types: macro hole without schisis, very similar in the aspect of the OCT to the emetropic eyes, worse prognosis, and to the right, the Kunontana described in 2006, macro hole with schisis. With inverted flap, some of you have shown images of inverted flap. Inverted flap, there are series, we published one of them, and we improved the results. We are able to close almost all cases with up and down, temporal to nasal envelope, as has shown before, retracting the oral partial up to down. I always use up to down. Why? Because my patients leave the OR walking, then I prefer to be seated or walking, and then the air presses and the ILM stays there. A difficult case, again the same principle. Distinguish between the ILM and the internal in the posterior hyaloid. This is the posterior hyaloid. This is elastic, poor stain, and this is the internal limiting membrane. Then you have to be sure that you are removing or peeling the ILM around the macro hole. Some cases you see like this, not regular staining, but you are sure that this is the internal limiting membrane. This is very rigid. And then you go around, and then at the end, you make your flap up and down, and at the end, you can close macro hole like this. The advantage to be, the third or the fourth speaker is that when Ramsey asked, mention the atrophy of the center of the macula. This has been published in 2019. But not only macro holes have been published in patients high myopes that for example, macular retinoschisis after vitrectomy, 3.3% show atrophy in the center of the macula. Foveal detachment, 4.4. Full thickness macro hole, 13.2, and macro hole retinal detachment near 30% of the patients. Look at this. This is patients of mine. 6 years later, the patient showed this, area of atrophy in the center. Look at this. 4 years later, this patient showed this area of atrophy in the center. But in some cases, the posterior pole is so wide that it's difficult to see the posterior hyaloid and internal limiting membrane. Is required to be sure that you re-stain 1 or 2 times just to be sure. Look at this. We peel all of these and then we re-stain, and I found more ILM, near the foveal area. with the schisis, let me tell you, you know, has been published by Japanese guys, very bad prognosis. You know, we did this paper with Macular buckle, you know, but, you know, Ramsey and other friends always told me, why you use, you know, Macular buckles in macular holes with the schisis? And then I say, okay, I trust you. And then I did my first case. This is my first case. This is the case, and this is the result. The patient was very angry. This is 3 months later, and I did a Macular buckle. But then I continued the series. As you can see, 8 cases. And this is the last case I shared with Ramsey, you know, 3 months ago in a meeting in Russia. And this was a patient with schisis. This is the last case. And look at this is the surgery. I did, you know, a conventional surgery. I did my vitrectomy, and I stained, you know, but the posterior hyaloid was there. I noticed it was there. Then I aspirated the posterior hyaloid. As you can see, the white ring. Don't go so far because you can promote breaks in high myopes. Be careful with the pigmented areas. Then I re-stained. And then I went to the center of the macular hole because some surgeons say that, you know, the viscous fluid inside the hole, you know, prevent the closure. Then I went there with a 41 gauge cannula to absorb, to remove this, you know, viscous fluid. Then, you know, I started my peeling in the inferior retina. You can see wonderful ILM, and then I trimmed this ILM in the inferior retina. And then I started my flap in the superior retina, and I went around, and then I put, it's not seen in the video, but I put platinum-rich plasma just to maintain the flap there. I'm working with this as a glue, not as a, you know, stem cells and all of this stuff or proliferative factors. But, you know, it acts like a glue, better than Hilon or viscoelastic material. Okay, at the end I aspirate in the inferior part of the retina, and I show in the meeting, in the webinar, I show the wonderful result. The patient was a really big angry. This is 3 weeks after the surgery. And, you know, I said to the patient, okay, go home, and in 1 month we will decide what to do. And then in the middle, you know, with Ramsey, we had this webinar, and Ramsey told me, don't wait, don't rush, wait. And let me show you, this is 2 months after surgery, and Ramsey was right, and 2 months after surgery, you know, the patient has this aspect, 2 lines improvement. This is not totally close, but, you know, I think we can consider this is close. Ramsey, I'm going to show you this case in 1 year, yes, just to know how is the vision acuity. Okay, in summary, in macular hole, high myopia, we have improved anatomical improvement has been great in these years. Re-stain to be sure that you build the ILM in eyes longer than 3 millimeters. Use always inverted flap technique. That's very useful to close the macular hole. In the macular hole with schisis, try first with inverted flap, and if fails, you know, you have macular buckets. Okay, thank you very much for your invitation, Mohammed. That's yours. Thank you.
So let me take the first ask the question or comments, Mohammed.
Okay, go ahead, Dr. Ramsey.
So Carlos, it's great. I listen your presentation many times, but every time I learn some different things. This is great. So today, now I learn what I learned. I learned the morphology of the macular central retina on OCT is very, very important for define the prognosis, so that we know this. So for that case, I'm really happy that I became right. And the results of a single layer inverted macular hole surgery, Carlos, like the optic maculopathy, we need time to see the good results. So it takes sometimes several months, and because the ILM cover the macular hole area, it creates a breach, and underneath the ILM flap, there's an empty area, and this empty area is filled by proliferation of glial cells. All the glial cells may collect there, and the ILM over the macular hole helps to closure of the macular hole step by step over times. So really thanks. So this is my just comment. Also, I would like to thank this for the great talks. Thank you.
My patients are very impatient, and the first patient was sent to me because they wanted me to do a macrobuccal. Then I convinced the patient to not to do it, and 2 months later, almost 3 months later, the patient was very angry, very, very angry with me because I convinced her to not to do it and say, "Oh, you weren't." And then I had to do it. And the last patient is happy, but let me wait 6 months. About the macular pit, optic disc pit, always you need time because you if you don't remove the fluid under the retina in the intraretinal fluid. But let me tell you, it's my personal point of view. I don't understand the ILM inside the pit. I don't understand it. For me. I did it some cases, and let me tell you, I do laser, and it works, absolutely works. Then I don't understand what's wrong with the ILM in optic disc pit. I don't understand it. I don't know why we have to peel it. But
I completely agree with you, Carlos, in the optic maculopathy about ILM peeling. I think we don't need to peel ILM. We don't need. We don't have any problem with ILM. So I agree completely with you. Even only the separation of the posterior hyaloid is enough to see the good results in optic maculopathy. We need time, several months, and then we see good results. I agree completely with you. Thank you.
Carlo, this is a very elegant talk. Can you hear me, Carlo?
Absolutely.
Yes, we can hear you.
My question to you is how frequent do you need to use the macular buckling whenever you have schisis associated with the myopic macular hole?
I stop it, Ayman. I stop it. Many people ask me why I stopped macular buckles in schisis and these kind of holes. You know why? Because I know by far better now the vitreoretinal interface than before. 20 years ago, 25 years ago, I was performing, macular translocation in myopic eyes. I did a lot, okay, huge number. I didn't know it. 25 years later, I had patients that they show macular traction maculopathy because I didn't remove the posterior hyaloid, and I was doing vitrectomy, and I moved the retina and all of this stuff. Then we have learned a lot with the OCT, with the failures, with the, and then now we know how to remove the posterior hyaloid, how to distinguish from the ILM. Then, I think it's enough for the relaxation of the retina with peeling of the ILM.
I can't agree with you more, Carlo, because we don't have it in Jordan. I haven't ever used it in my myopic macular hole, even with schisis, and I've done it without it, and we have good success without it. This is why I asked you. So I can't agree more. I totally agree with you.
Thank you, Dr. Ayman. Dr. Ahmed, have a question?
Thanks a lot, Dr. Carlos. A beautiful presentation as usual. I think you answered the question that you initially asked about the membrane peeling for the lamellar macular hole. How you do it, you need to double stain, sometimes even triple stain, if you are not sure that you are peeling the actual internal limiting membrane. So this is always the clue. Visualization, like in your beautiful videos, is excellent. And despite that, you show that after restaining, you discovered that there is still remaining ILM. So this is beautiful. And I agree with you totally about the flap, ILM flap in such cases. It's the way to go.
Let me tell you, when I mentioned the study your OCTs, this is crucial. When you see the OCT with double line over the retina, this is this kind of fluffy tissue that is very difficult to remove. Then I use the flexible loop. I go there, very patient, not to press too much, but you see this fluffy tissue coming out of the retina. If you stain, you will see the internal limiting membrane. You remove this and then you stain. But again, when you see this fluffy tissue, the prognosis is worse. I don't know why, but in the macular holes, in the lamellar macular holes, in everywhere. When you see this fluffy tissue, the prognosis is worse.
One question: do you think that using longer acting gas may be helpful to flatten these pieces? because the notion of using no face down positioning in macular holes or large macular holes, actually, personally, I do not really agree with that. I feel that giving time to the patient using maybe a longer acting gas in larger macular holes or macular holes in myopic macular holes with foveus cases maybe will help to close these cases spaces even better and maybe help the patient to recover the vision even earlier.
Let me tell you, I only use SF6 20% only, or 5%. I never use C3F8. Never. You know, I do OCTs the day after in all of my patients with macro hole. High myopes, you know, in a high myop, phakic high myop, you don't see anything. But, you know, in a pseudo-phakic high myop, you can find in the macro hole. Macro holes close in between 24, maximum 48 hours. The rest are miracles. You know, I saw miracles, but, you know, they tend to be closed the first 24 hours. Then you have to maintain this. And I tell my patients to be 3 days face down or 5 days face down. But
that's what I meant.
Dr. Hassan, please. Yes.
One more question for Carlos. Great presentation as usual. I would like to ask about this patient who's having really large posterior staphylomas, large axial length, and the remnant of the retina, where usually is it the same mechanism that of your surgery, or you have to modify it a bit? Because this is where the ILM needs to be clean from this area, because the slope between the sclera and getting in the staphloma, it might make the difficulty sometimes. With residual, most of the time of the abnormal vitreous, that what's if you peel is not gonna out.
Yeah, you know, when these are very big posterior staphyloma, very profound, very deep, you know, be careful. Be careful, two things. One, you know, you are here and, you know, the eye is down, then your movements are amplified down. This is the first. The second thing is when you go to temporal, be careful because you are near the vertical wall of the staphloma. Then you can touch the retina and promote a break. But I agree totally that it's more prone to promote breaks. I want to ask you, to all of you, if you have a foveal detachment, imagine that you have a deep staphyloma and you have detachment of the retina, but only no holes. Would you absorb, you remove with a cannula this fluid? Will you make a hole just to remove this fluid, or you put gas?
Can you ask Dr. Gridhar to give this, please? Yeah.
Put gas.
And you don't aspirate the fluid?
No.
You don't, you know, because some people, I did, you know, live surgery, and then, you know, I remember one in Italy, and one surgeon told me, I would make a retinotomy to aspirate this fluid. Be careful, because you are in the area of the staphyloma, and the retina is stretched. Then if you make a hole there, the hole will enlarge. Can enlarge. If it's large, you're done. It's very difficult to close.
So, Rashid, do you have any comment before we move to a second talk?
Thank you very much. It's clear.
Okay, Dr. Ahmed, Dr. Ramzi, anyone? Okay, thank you, Dr. Carlos. There is a question, so be with us from a participant. In the end, we will ask this question. So, Dr. Ahmed, you want to introduce the next one?
Yeah, so Dr. Gerdhar, he will talk about the approach to macular traction in complex diabetic retinal detachment. Can all mute?
Yes, please mute.
You can see my presentation, sir?
Yes, go ahead, Dr. Gridhar. Yeah, everything's clear.
Thank you. Thank you very much for giving me an opportunity, and thank you, I mean, with a very, very, very experienced panel, and I will be presenting a few cases of complex proliferative diabetic retinopathy with macular traction. And probably we can, I mean, being so many experts here, they can also give their opinion regarding the management. So my first patient is a 46-year-old patient with a defective vision in the right eye. The left eye also has got very poor visual acuity. And this is the color photograph, montage photograph to show you the macular traction retinal detachment, along with a large fibrovascular proliferation. This is one of my simpler cases, which I'm showing you. And now I use the cutter as a you can see here, this is the, I use the 25 gauge system as far as the surgery is concerned. And in this case, I'm doing the outside-in technique, whereby I'm identifying the posterior hyaloid from the periphery and reaching the center. And I'm showing a unimanual technique where I'm using the cutter for all the manual maneuvers. I use the cutter as a forceps, identify areas of separation, and use the lift and cut technique to dissect and segment the fibrovascular proliferation and release the traction in the macula. And subsequently, again, I do the lift and cut technique whereby I go underneath the fibrous tissue and eat it up and create small islands which can easily be eaten up. And I use this technique where in smaller membranes, which are more flexible, we can keep the cutter on the surface of the tissue and just eat it up. And by this technique, with a single instrument, with using the lift and cut and using segmentation and delamination using the cutter, I think we have been able to remove all the fibrovascular proliferation. And this is the complete picture after removal of all the fibrovascular tissue. So this is the post-operative photograph showing an attached retina. This patient, of course, was a recent macular TRT, and therefore the visual acuity improved reasonably well. This is my second case. This is a more complex case of detachment, where you can see this large fibrovascular tissue and macular traction. And here also I start the outside-in technique using the 25 gauge cutter. We've had to first identify the area where the hyaloid is raised, and hyaloid is raised, and slowly dissect from periphery to center. And basically, once I reach this dense fibrovascular tissue, so I make a large opening here and extend it on either side. And once we reach here, we see that this whole area from equator to the posterior pole involving the macula, there is a large, towards nasal side, there's a large fibrovascular tissue, which is densely adherent. So here I move on to the bimanual technique. And in bimanual technique, we need to identify from where we start the bimanual dissection. And here I can show you the vitreoscheisis, where you can see the second membrane underneath. And unless and until we may dissect and make an opening in the second membrane, we will not enter the correct line of cleavage. So here I am using the blunt scissors, the curved scissors actually in this particular case, and therefore gently dissecting and trying to identify the area from where I can start my dissection. So you can see here, you can see the scheisis here, and you can see the second membrane underneath this white tissue. And I gently extend it horizontally. And now I've been able to enter identify the correct plane. And with this, I start the dissection. So this is a very large tissue. And slowly and steadily, I'm trying to do an en bloc dissection, where I'm trying to release this large fibrovascular tissue one end to the other, focal areas of traction, and also by using the blunt dissection, identifying the more dense area of traction. So here I'm using the forceps and the scissors to slowly dissect this particular tissue. So here you can see here, and you can see this is extending practically up to the ora serrata. And the reason why I'm doing an en bloc is one end to the other is that I release the horizontal traction also simultaneously. So this way I've been able to, in this particular patient, I've been able to practically remove all the total excision of all the membranes. And there are focal attachments right up to the ora serrata, which again was dissected. And it's very important to prevent any iatrogenic breaks. in this situation. So you can see here there are some focal attachments which are again released, and subsequently that's also eaten up. So this is a more complex case where the total dissection end to end and the whole thing has been removed. So this is the post-operative. This is the third case which I want to show you. This is again a very complex case of a proliferative diabetic retinopathy, bilateral disease, untreated, treatment-naive patient. And if you see here, you can see the OCT, and the OCT can show you, it's very important to do a wide-angle OCT. In some of these cases, I do a wide-angle OCT, and you can see the separation of the membrane, the posterior pole, and also we can identify the vitreosisis. And when you do the B-scan ultrasonography, you can see the multiple membranes, and you can see that there are multiple membranes, and also gives us an idea where to start the dissection. So this is a video showing you this complex case of a macular tractional retinal detachment. And in this case, actually, I used the chandelier because I knew that we have to go in for a bimanual dissection. I prefer the bimanual dissection. I don't do much of viscose surgery like Carlos. And probably because I've been doing this for many years, I got used to this technique. So here what I do is I first identify wherever there are areas of separation, and I segment the membranes initially so that, create more islands, so that the remaining portion probably can be taken up with a cutter. In this particular case, what I want to show is the dense fibrovascular tissue in the nasal quadrant. And this is very difficult to dissect. The visualization and also the approach is very difficult. So here I'm trying to dissect this particular dense fibrovascular tissue, and I'm not getting a good approach to the membrane, and probably we can ask the experts as to how they will handle this difficult situation where we have this very adherent fibrovascular tissue with an underlying detached retina. So I'm trying various techniques here. I first tried from here above, now I come below because I felt my reach is better here, because my main problem is I'm not able to get a good hold. For this point of time, I change my position. I come to the temporal side. I change the position of the cannula to the nasal quadrant, and I push the chandelier also to another quadrant, and I come to the temporal portion, and I start operating from the temporal side so that I'm able to visualize the nasal retina. So with this technique, I start the dissection, and I find that I get a good approach and a good visualization. And with this technique, I was able to practically dissect this dense fibrovascular tissue and practically remove all traction. And also I was able to remove at least 80 to 90% of the membranes present in this particular quadrant, at least up to the equatorial region in this particular case. So you can see the post-operative photograph. Patient improved to 6/60. There are 2 or 3 small islands of fibrovascular tissue remaining, but otherwise the retina is attached and the traction has been completely removed. This is my fourth case showing peripapillary and macular traction in a patient with a taut posterior hyaloid. So here I start from the outside in technique. I use triamcinolone in some of these cases because I find that diluted triamcinolone, which stains the posterior cortical vitreous, and sometimes also forms a small layer on the hyaloid, and also is able to identify the additional membranes on the surface of the retina. So subsequent to that, I make an opening in the hyaloid, thick hyaloid, using the 25 gauge spatula. I use these 25 gauge spatula and make a opening in the hyaloid and gently try to lift it circumferentially to see whether there is a good separation. So slowly and steady, so this is showing a good separation, and I slowly release it from the posterior pole towards the equator, and just lift it up so that this is lifted and makes the surgery much easier now. And this may, up to the equator, we can release the membranes, but from equator to ora, again, you may have a very dense attachment where I may use bimanual dissection or sometimes a little bit of viscose surgery too, because I'm very particular that at least in the inferior quadrant, I need to remove the hyaloid and all the membranes up to the ora serrata. You can see here, Inferiorly, as I told you, there are little dense attachments, but using mild suction, I release it and then give the endolaser photocoagulation. This is my technique of endolaser, where I go from the posterior pole to the posterior periphery, parallel to the retinal vessels without injuring any of the major retinal vessels. This is my last case. Of course, this is a case of a combined detachment, which probably does not fit into the talk that has been given to me. This is a patient with a combined retinal detachments. The combined retinal detachments are of various types, and this probably is not a very difficult case where in the inferior portion, the membranes were raised, the hyaloid was raised, so I made an opening there. And from there onwards, I moved to the upper quadrant where the retina is detached. And this area, I lift the membrane. This is the retinal hole with a thick fibrous tissue here. And it's very important for us to release all the traction, if possible, remove this fibrous tissue from the surface of the retina. So I'm using the peeling technique where I'm using little force to pull it up, and then finally I'm just removing the complete fibrovascular tissue and releasing all the traction in this particular, combined retinal detachment with a hole in the upper temporal quadrant just outside the macular arcade. So these are my few videos. Therefore, in complex retinal detachment, proliferative diabetic retinopathy, I think each one of us have our own techniques. I use preoperative anti-VEGF in cases which are treatment naive and very vascular tissue. Careful intraoperative assessment initially is necessary to identify areas of separation and the various areas where the membranes are raised so that we can start the dissection accordingly. In the posterior pole, it's very important to identify specific areas of dissection, and probably in dense cases with dense adhesion and dense fibrovascular tissue, a combination of various techniques will be necessary. I use wall cannulas, 25 gauge system. I put in a chandelier in most of these cases because it gives us good illumination also, and it's very easy to change to a bimanual technique if necessary. I think surgery requires a little bit of patience, and post-operative outcomes as well as vision, of course, is unpredictable. But in situations where patients have bilateral advanced disease, I think we should try as much as possible to give at least ambulatory vision. Thank you.
Thank you very much, Dr. Giridhar, for this really excellent and comprehensive presentation. And thanks for being with us. I know it's too late for you, but you are most welcome, and we appreciate being that with us till this time. If there is any questions to Dr. Giridhar, please.
Dr. Giridhar, this is very, very elegant videos, beautiful, and I can appreciate your suffering because we are dealing with these cases daily. Our patients, they presented late and they presented with very advanced proliferative disease. I congratulate you. Do you give anti-VEGF pre-op, as I routinely give my patients before surgery, because I like to go into a dry retina rather than...
I can't hear.
My question can you hear me now? Hello? You can't hear me.
Dr. Giridhar, you can hear us now?
No?
No.
Just let me say one comment.
Okay, very fast, Dr. Ayman, so maybe we can give him a chance to ask.
About when you have an epimacular membrane, and I've seen Dr. Giridhar, he removed it using the spatula. I want, just from my experience, we have to be very cautious sometimes trying to elevate this membrane from the macula. You will get sometimes very nasty bleeding. So especially if you cannot see underneath. So whenever you have such, I think Dr. Giridhar is a very experienced surgeon. He's done it. But I'm talking to my other colleague.
No,
Don't ever try to remove it. It's tempting to remove this. It's easy to pull it up, but whenever you are doing most of the time, you will get a very nasty bleeding. So be careful in dissecting this membrane. My question to you, Dr. Giridhar, is: do you use anti-VEGF before and after surgery?
No, to answer your first question, sir, I fully agree with you. And normally I do not remove the hyaloid or the fibrovascular tissue on the optic disc till the very end of surgery, because it can cause severe bleeding, number one. So in this particular case, since I knew that it was a very thin membrane, and I knew that, based on experience, that the chances of bleeding was very less, and that's why I did it. So, and number three is in the OCT, I had seen already that the macula was lifted and that there was a significant gap between the membrane and the retina in the region of the macula. That's why I attempted that particular technique. Otherwise, normally what I do is I make a small opening and use the lift and cut technique with the cutter. I don't go in and try to lift it like this, so vigorously with the instrument.
Yeah. This is why I don't want the audience to get the wrong idea if they can do it easily.
Yeah.
Thank you very much. Yeah.
So that is number one. Number two is, as far as the anti-VEGF is concerned, I use preoperative anti-VEGF in, as I told you, in treatment-naive patients and in eyes where there is active fibrovascular tissue. But at the end of surgery, I don't use any anti-VEGF.
Okay, is there any question to Dr. Giridhar? Okay, before we move to Dr. Ramzi. Okay, Dr. Ramzi.
Actually, I missed most of your talk, Dr. Giridhar, because of my internet problem. But yes, I just want to ask about your tamponade preference after surgery. When they finish the patient without any iatrogenic tear, if there is no any tear previously, and peel the membrane, there's exudative detachment and viscous fluid underneath the retina, but there is no tear. What's your technique? Do you do retinotomy to remove the viscous fluid or not? Or if not, do you use tamponade or not?
I mean, I don't create a retinotomy to drain the fluid if there is just a focal area of fluid. That is, if just a macular traction detachment and there is no hole, I'm a little reluctant to create another hole and create a hole and drain it, because usually it goes off with tamponade. I use gas tamponade. And in diabetic vitrectomy, I prefer to use C3F8 10%. I don't use 13%, I use 10% C3F8. Because I don't want the gas to stay too long in the eye, because the problem with C3F8 is we are not able to see the retina for some time. Therefore, I use 10% C3F8 in these sort of cases. But if it is quite an extensive detachment, yes, I may do a peripheral retinotomy and drain the fluid.
I want to add to only one point. Ayman, Dr. Giridhar, you're right. Don't pull the optic nerve. Don't leave it there and do light diathermy. You don't need it. Never bleeds there. I ask this question in every meeting. In every say, okay, I remove it. Don't remove it, because it's not a problem during the surgery.
Not necessary, yeah.
The day after you will have full of blood inside the eye. Then don't remove it. Diathermy is nothing more. And Ramzi, I removed the fluid. I removed it. I'm so sorry.
So what am I doing? If there is no retinal tear, if there is a limited subretinal fluid, I do not do retinotomy. I do not use any tamponade material, because if there is the retina is intact, the subretinal fluid resolve by itself. Takes times, but it resolves. If there's exudative huge detachment, yes, you're right. We should remove, Carlos.
Do you use air at least? So you don't even do a fluid air exchange?
No tamponade materials.
Great.
You are very courageous, Dr. Ramzi. For me, I always use tamponade, either air or gas, usually SF6. I always prefer gas than silicone, but whenever silicone is indicated, I would not shy to use it. And I'm really emphasizing on the point that Dr. Giridhar just mentioned, that using multiple techniques. He has shown in, out, and out, in. So there is no one way to go, because we all hear in, out is the way to go, or out, in is the way to go. It is always whichever case applies. I think this is the way. And you apply different techniques at the same case, because we face these difficult cases with huge traction retinal detachment. The difference of, in my hand, unimanual versus bimanual, whenever there is no excessive traction on the retina, you are not pulling the retina too much. If you can go with unimanual and cut all these membranes without causing any iatrogenic tears or pulling the retina too much, I think you can do it. Or like Dr. Gidhard beautifully have shown, bimanual technique. My question is, do you use ILM peeling in such cases to relieve any further hidden traction?
I do ILM peeling only in cases where I find a macular hole. Only in cases where I find a macular hole. Otherwise, I don't do ILM peeling.
Comment. You know, I in the case number 2 and number 3, you mentioned, but I would use viscodelamination. You know, it helps you.
No, I know. I have seen you. I have seen your videos on viscodelamination. So yeah.
You know,
sure. Dr. Hassan, please.
Yes, really, I'm not doing ILM in these cases unless there is a macular hole, and rarely I use Timbaland for TRDs without any breaks. Usually I let it to go, and most of these cases resolve within maybe take weeks, but it is okay.
Dr. Rashid, please, before we move to Dr.
Sometimes we face such cases, those is severely ischemic retina cases, diabetic. And it's a special maneuver do you recommend? Because those patients, when you start doing anything, you find the retina gets black cracks and holes, and you want to do something for the patient. As you said, you can, at least to gain some vision. And it's special advices.
No, I think in patients where, you know, in such situations, what I can only say is I think we must try and remove whatever traction is there. At least remove whatever traction is there in some of these cases where the retina is very thin and when you have these very adherent tissue, probably you may not be able to do a complete dissection and removal. So at least we must remove all the traction. But then leaving membranes on the retina, I think basically leads to reproliferation. So over a period of time. But then that's the only thing that we can do. I don't know whether Carlos would like to say anything.
You know, reproliferation does exist, but you know, with the anti-VEGF now, you complete at the end, you complete your panretinal photocoagulation, you go to a periphery, and you complete all of this, then you decrease. You know, 30 years ago I had reproliferations. Now it's very rare. You know, because of many drugs and laser, and you know, and we improve it. But you know, I try not to leave anything except the optic disc, and you know, if it's too risky, leave it to lay around and leave it. It's better to leave it than to break it.
Yeah.
Thank you very much. Okay, can we go now to the last presenter, Dr. Ahmed?
Yeah, the last presentation, definitely not the least, by Dr. Ramzi Abdi about the treatment of submacular hemorrhage.
Okay, thank you very much again for this kind invitation, Dr. Mohammed. It's a pleasure for me to be here. And today I will speak about the management of submacular hemorrhage. In my talk, I have these are my financial disclosure, but none of them are related with these topics. As you know, there are several etiologic factors for submacular hemorrhage, but neovascular age-related macular degeneration is one of the most frequent reasons of this pathology. And the natural course, as you know, it's not good, and severe visual loss was reported in 80% of patients, and the worst prognosis is related to the extent, height, and duration of subretinal blood, and also recurrent hemorrhage. The worst prognosis on natural course is related with the toxic damage of fibrin, hemosiderin, fibrin, and iron, and also deficiency of nutritional excess with the separation of photoreceptors from RPE by cloth, and tissue disruption secondary to mechanic damage by cloth, and also scatter cell change and secondary fibrin root contraction. And therefore, no more discussion left today about displacement of submacular hemorrhage without delay with different techniques. So there's no standard classification for this pathology, but Michael et al. Reported this classification extent according to extent and thickness of hemorrhage as small hemorrhage within arcades, large hemorrhage, reach to arcades, and extensive hemorrhage beyond arcades, and massive hemorrhage beyond equator, at least 2 quadrants. And again, thin and thick hemorrhage over and under 500 micron thickness. So there are several treatment options, but vitrectomy with intravitreal or subretinal TPA and gas tamponade is the most widely accepted method today. And this is not really difficult technique. And in this technique, after removal of vitrectomy and separation posterior hyaloid, we use 41 gauge cannula to inject anti-VEGF and TPA to the subretinal space. But the key point, the most important point during this manipulation is we should pay attention to create enough retinal detachment area, especially to the inferior part of the retina, to be able to displace the clot as a clot from macular area to the inferior retina. So we have some examples after this surgery, and this is the first patient is the hand motion vision with extent hemorrhage. This is 4 weeks after surgery, vision improved to 4.5 and almost complete displacement that we observe in the B-scan LCT. You can see the perfect attachment of the sensor retina to RPE after surgery. Another patient with extensive hemorrhage, again 3 weeks, just 3 weeks after surgery, again complete displacement, and you can see the level of the air and the vitreous cavity. And on the OCT, again, we observe good macular configuration after surgery. And this is another patient before and just a week after surgery, and just 3 weeks after surgery, we observe all complete displacement. And also on the macular, on the OCT, we observe perfect macular configuration 1 week and 3 weeks after surgery, and we observe significant visual improvement in this patient. However, in this patient, we observe recurrence of a disease with a serious pigmented detachment. We continue to do anti-VEGF treatment, but unfortunately, under the suppression of even under the suppression of anti-VEGF, we observe rebleeding, but the center of the file was open, and we continue to do anti-VEGF treatment. So to continue the anti-VEGF injection after surgery is mandatory in this patient, and we never leave this patient after surgery and rebleeding because of the rebleeding and recurrence of this disease. This is a massive hemorrhage. The thickness of the hemorrhage was more than 1,000 micron. Even in this patient, we observe complete displacement. As you see, we can see the hemorrhage in the inferior part and beyond the equators as a blood clot, complete displacement in this hemorrhage. So sometimes when we inject fluid to the subretinal space, we could not manage to detach the retina through the inferior part of the retina, as you see here. If we not the retina is detached through the superior area, then I apply another detachment to the inferior part with 41 gauge BSS injection from different area. Then I apply fluid air exchange and connect the detachment. So I really pay attention to detach the inferior part in extensive and massive hemorrhage cases. So in this patient, this is before and just 3 weeks after surgery. Again, you see complete displacement of hemorrhage to the inferior part of the retina, and vision observe significant visual improvement in this patient. Also, we apply this technique in massive hemorrhage, as you see in these pictures. And for this patient, also, we do the same technique. We create a retinal detachment to the temporal area, not only inferior part of the retina because of the massive hemorrhage. And we keep the patient's reading position, and temporal side is of the eye is behind, in the close to the ground. And this is before and just 3 weeks after surgery. Again, we observe complete displacement. So we collect 30 consecutive eyes with neovascular AMD, with this etiology of neovascular AMD patients, and the mean duration of hemorrhage was 13 days. Maximum is 30 days, and most of our patients, the hemorrhage was large to massive, and 24 out of 30 eyes we observe large to massive hemorrhage, and also the thickness of the hemorrhage was more than 500 micron in 25 eyes. So the mean area of the hemorrhage was about 61 millimeters square, and the mean thickness of the hemorrhage was almost 750 micron. The minimum thickness was over 400 microns. So in our surgical technique, we apply the total of 50 microgram TPA subretinally and then standard dose of bevacizumab subretinally. And we applied 5% C3F8 tamponates and only partial fluid air exchange, only 2/3 of the vitreous cavity, and we keep the patient reading position after surgery for 3 days. We observe submacular hemorrhage displacement in all patients, but it was total displacement, means beyond the arcade. All the hemorrhage was beyond the arcades in 53% of patients, and subtotal, this is mean that thickness of the hemorrhage was less than 100 micron under the fovea. And in 46% of patients, we observe rebleeding in 2 eyes and apply repeat surgery 1 and anti-VEGF injection the other eyes. So we found significant improvement in visual acuity during this 6-month follow-up period. However, there was no significant correlation between pre-op visual acuity, thickness, and extent of hemorrhage and the post-op visual acuity during the follow-up periods. And submacular hemorrhage duration was the most important prognostic factor in our study, and we observed significantly greater improvement in best corrected visual acuity in the early intervention group treated within 10 days after hemorrhage. And the other point is that relation with the total displacement duration of hemorrhage and the mean duration of the submacular hemorrhage was significantly shorter in patients who achieved total displacement of the hemorrhage. So that means the shorter duration, the more better total displacement hemorrhage that we observe. So we can find some modification of this technique. Sharma et al. Reported their results in 3 years ago with subretinal air injection. They combine this technique with subretinal 0.2 milliliters air injection in their technique with a partial fluid air exchange, and they reported 100% displacement of blood from the foveal centers. So we apply this technique in case with small to large hemorrhage, as you see here. After injection TPA and anti-VEGF, we inject subretinal 0.2 milliliters air. We did not do any fluid air exchange, just inject air to the subretinal space and keep the patient's reading position again 2 to 3 days after surgery. This is, as you see, before a week and 5 weeks after surgery, observe perfect macular configuration. Another patient with myopia, and before and after this surgery, again, we observe good results. So maybe this technique, subretinal air injection without fluid air exchange, may apply small to large hemorrhage, not extensive or massive hemorrhage. So the crucial point in surgical technique is 41 gauge cannula, subretinal cannula is ideal for injection. Injection must be applied slowly because of risk of macular hole during the fast injection. And the other point is sufficient subretinal space should be created, especially in the inferior part of the retina, to permit displacement of subretinal cloth. Another point is attention to RP detachment, and we should do injection away from the RP detachment to risk of RP rupture in this area. And which technique and which TPA dose is better? We found more than 60 articles on PubMed, and most of them are retrospective inclusion criteria, surgical technique, and drug dose and amount, and also comparison criteria of the results are highly variable. And intravitreal gas versus intravitreal gas and TPA, or intravitreal TPA versus subretinal TPA, the results are really controversial. And Graham et al. Reported their results very recently. 85 eyes with submacular hemorrhage due to neovascular macular degeneration. They applied 3 different techniques. In the first group, they applied intravitreal TPA without surgery. And second group, vitrectomy with intravitreal TPA. And the third group, vitrectomy with subretinal TPA. And they couldn't find any significant difference between these 2 group results. And they concluded that, and that none of the technique had any clear advantage over the others. So, in conclusion, subretinal TPA Antiv Jeff injections in submacular hemorrhage is easy to perform, safe and effective technique. However, the management of submacular hemorrhage is controversial, and standardized management protocol still does not exist. And we don't know which technique should be opted according to the extent of hemorrhage. And also various factors can determine the final outcome and the prognosis of vitreous hemorrhage. And therefore, we need further prospective and randomized studies to find which technique is best technique for which case. Thank you for your attention.
Thanks a lot, Ramzi. Thanks a lot. Very interesting. So, if there is any question for Dr. Ramzi?
Ramzi, can I ask you?
Sure.
Definitely, it's working very well in case of subretinal hemorrhage. But the problem when you have a subretinal and subretinal pigment epithelial hemorrhage, where you can see this dark ring in the middle, denoting that there is an addition of dense subretinal pigment epithelial hemorrhage. Do you change your technique or you just do the same? And the other thing is that I faced with one of my cases an exudative detachment of the lower part of the foveal area and the retina. And in fact, it stayed for some weeks, and I was about to go and to go in and try to inject gas, but I was a little bit patient, and ultimately it went away. Did you have did you have such a complication among your cases of exudative detachment of the fovea?
Mm-hmm. So I think for RP detachment, really we should be careful, and I think intraop OCT may help to define the extent of RP detachment during injection. But usually in injection, Ayman, we can see clearly the subretinal space. We can find some area of hemorrhage that we clearly see the RP detachment and the retinal detachment area. So in my practice, I did not have any such complication. I did not do any RP injections, but on the literature you can see some complication that it's easy to inject through RP. But practically, it's not difficult to define RP detachment area and retinal detachment area during injections. So the question that exudative detachment, in that patient, there was any retinal tear or retinal defect?
No, there wasn't. And in fact, a few weeks later, it was absorbed totally. Good that I observed it for this.
I did not have such a case. I did not have any experience.
It was only one case that I have this exudative detachment.
But the important point in this technique, we should pay attention to not create any retinal tear, because if you do this, all the subretinal blood can come in front of the retina, and the resorption of blood takes time. And sometimes in massive hemorrhage, you need to do second surgery to remove all the subretinal blood. And therefore, I always pay attention to not do any retinal tear, any retinal defect during these manipulations.
Absolutely right, because we are using the 41 gauge, and what I used in the beginning, I was using the manual technique. I just use my hand to inject. Nowadays, no, I use a more controlled technique where I use my foot pedal of my vitrectomy through a special syringe, and this is a very controlled way of injecting the TPA under the fovea, and it is very nice. And in cases of massive hemorrhage, what I do nowadays is I do multiple injections. I inject in more than one site, and I found this more helpful in resolving the hemorrhage post-op.
Thank you, Dr. Ayman. Okay, Dr. Carlos, yes?
Two things. I was astonished. Congratulations, because the results are, for me, are crazy good. The problem with the RPE is not to inject in the RPE. As you mentioned, it's very easy to distinguish where is the RPE, elevation, or you can go away even the subretinal hemorrhage to be sure that it's not there. The problem is that you are moving the subretinal hemorrhage, but you are doing nothing to the sub-RPE hemorrhage. This is, for me, the problem. Because you show cases with sub-RPE hemorrhage. I saw the OCT, and for me, these are the worst. If you have a subretinal hemorrhage, that's done. It's pretty easy. But sub-RPE hemorrhage, the problem is that you move the subretinal hemorrhage and the RPE remains there. And at the end, you keep injecting. At the end, many of these cases end with, in my cases, ended with a scar in the center. Then, this is the first. The second, you mentioned to avoid the macular hole, always go a little bit away from the foveal center, because it's the thinner part of the retina. And then, but I was astonished with the results in your pictures. It was amazing. Congratulations.
Carlos, in this case, yes, the sub-RP hemorrhage, we do not do that for sub-RP hemorrhage, but I observe after this technique, when we keep the patient face down position or reading position several days after, for a few days after surgery, I observed that the size of the sub-RP hemorrhage is reduced more fastly than the standard resorption period. I don't know why. Maybe the gas pressure is gas temperature helps to resorption of sub-RP hemorrhage also. But this is my observations.
The OCT were clear,
Yeah. Even just several weeks after surgery, you see the OCT. The size of the RP hemorrhage is really significantly reduced.
Thank you, Dr. Ramzi, Dr. Carlos. We can go to Dr. Gridhar. We are having only 4 minutes to finish all. We have
we have some questions from the audience. So
Gridhar, can we have Dr. Gridhar first? Yes.
Dr. Ramzi, I just had one question to you. I mean, very nice presentation. The case where you had that large, massive hemorrhage,
yes.
You injected the 41 gauge. The hemorrhage was in the inferior quadrant, right?
Yes.
And you injected in the upper quadrant, right?
Yeah. In this patient, I didn't show all the video, Dr. Grihart. I inject TPA and Antiv Jeff through the inside the hemorrhage area, but then I also inject BSS to the temporal part of the retina to detach the temporal part, because in this patient, the massive hemorrhage was cover all the inferior retina, and I plan to displace the submacular hemorrhage to the temporal part. And after the surgery, I keep the patient reading position, and the temporal side is a little bit close to the ground, and observe that the hemorrhage was displaced to the inferior and temporal part. And therefore, I did a subretinal BSS injection to detach the temporal retina in that case.
How many days? I mean, suppose a patient comes with a 1 month history. Would you do the same procedure? 1 month history. Suppose the patient comes with a history.
So the duration is very important. After 1 month, also in some of our patients was like 25 days or 30 days, but the result was not as good as it is short duration patients. So in 1 month, I think all the hemorrhage came is very strictly blood clot, and it's even in your displays, the visual result is not really good.
Dr. Hassan, last comment, please.
Just in my practice, I don't do it if the patient duration is more than 2 weeks. It's up to 2 weeks. I do it. More than 2 weeks, I find the results would not be as
good.
Hassan, Dr. Hassan.
I do the same as Dr. Ramzi, using 41 needle, and then I get cannula and injected 25 microliter of TBA. I'm using some rolling maneuvers immediately post surgery. Is it advisable, Dr. Ramzi? Because you are keeping patient in reading positions.
Yeah, just reading positions. But when you ask the patient to keep the reading position, but it never keep the reading positions. They move some manipulations, so it's kind of, but it's okay. But I ask the patient, keep your position, the reading position for 3 days as much as possible. But not any special manipulation except this.
Thanks a lot, Dr. Ramsey. I think we can go to answer some of the questions from the audience. Quickly, 2 questions for Dr. Carlos Mateo. Is the fluffy tissue over the macula same as the epiretinal proliferation described in literature?
Yeah, it's similar to this. Was reported. Barbara Parolini and a German group described one thing, and the Rick Spade described other thing. But you know, it seems that this is a degenerated vitreous over the retina. This is typical fluffy and yellow. Some pigments of the fovea are there.
Okay. So the second question, do you always use contact lens for ILM peeling in myopic patients? Which is the ideal lens in your hand?
I always use flat lenses. I want to see also only the macular. I use the macular window lens. This is from AVI Instruments. Yeah, this is, you know, the stereopsis with this lens is amazing. I never saw something, you know, similar to this. But you work in a very small field. You have to be aware of this. You know, my videos, you see the forces like, you know, but it's a small field. It's a small field.
Yeah.
You know, you see what they're thinking.
Yeah. A question for I think Dr. Gilhard. In eyes with combined retinal detachment with fixed folds, radial, in contact with retinal break, what is your approach?
Can you just repeat it?
In eyes with combined retinal detachment, traction rhegmatogenous, with fixed folds, radial, in contact with retinal break, what is your approach?
Yeah, I think I showed a video with a patient with a combined retinal detachment with a tissue and a detached retina. So basically, I mean, once we release the traction, the radial fold is basically because of the traction. And once we release the traction, the fold will get released. So I don't think there's anything extra to be done.
Okay. One question for Dr. Ayman. Nice talk. What is the chance of progressing to full thickness macular hole? Any particular factors to look for?
Well, the chance of a lamellar hole progressing to a full thickness hole is always there, but it's not a big chance, except as we said, if the lamellar hole is in a high myopic patient or in a patient in probably a diabetic patient with a traction. Yes, there is a bit higher chances for these patients to develop a full thickness macular hole. But in immetropic patients, lamellar hole are rarely transformed to a full thickness macular hole. The other thing is that while you are doing the surgery and you are peeling an atypical epiretinal membrane, there is a chance, if you are not careful, to convert a lamellar hole to a full thickness macular hole.
Thanks a lot. I think there is another question, Dr. Mohammed.
In chat, yes, Ahmed.
Go ahead. There was a question from Dr. Devakani Suresh to all panelists. If we have small retinal break at the I don't know this, UNQ, at the base of the meridional. Patient is high myope, 24 years old male, asymptomatic with long-standing complaints of floaters. Should we laser him or can we wait and watch? Thank you. I think as long as if it is symptomatic, and there is a retinal break. The break is always different between hole and tear, a flap tear, and there is some floaters. And if there is any vitreous traction, I would definitely laser to prevent progression. But if it is asymptomatic and there is no risk of vitreous traction and it is a hole, I would just wait and observe. I don't know if anyone has other opinion.
I would wait, but it depends on the patient is thinking. If the patient is very, very nervous and they are asking for treatment, I would treat it, because, you want to be the
No
patient.
harm.
Yeah, of course.
But
you make the, but
if it's
understand it and you explain it, the symptoms and everything, I would do nothing.
But if it is myopic patient, Ahmed, I usually prefer to do laser. But if it is standard patient, if it's whole, it's asymptomatic, I leave without laser. But in myopic patient, almost more try to do prefer to do laser.
It goes to the debate of the LASIK, and if you have tears or holes before LASIK, whether to do it or not to do. It's a big debate. But,
legal issues there.
Yeah.
Okay, thank you very much for all of you. It was a great meeting and sessions. Actually, this is the last session for our conference. I thanks all of you. Really appreciate your being with us and accepting our invitation and being with us actually to the last minute. If there is anyone to say something starting from Dr. Hassan.
I would like to thank you and congratulate you for this really big meeting, virtual, that over 3 days. And when I look for compared to the other meetings done in the same area, it's really successful meetings, and really congratulate you and your team and all the participants as the speakers. Thank you for all, and give us a chance to be with you guys.
Thank you, Dr. Hassan. Dr. Carlos.
It has been great. Thank you for counting on me, and it has been great to see you all very good, with health and everything. And thank you very much. I enjoyed a lot and I learned a lot, and thank you very much.
Dr. Ramzi.
Thanks again. Thanks for everybody's. I learned a lot of things tonight. But the special thanks for you, Dr. Mohammed. You had a great job. You did a great job. So it's really good to be at least see each other in a virtual screen and to discuss and to share experience. Thanks again for everybody's.
Dr. Grithar.
Thank you. I mean, very nice. Both the sessions, the medical retina and the surgical retina sessions were very good. And as Francie said, a lot to learn. I think especially the technique. Carlos, any number of times we listened to him, I think I don't know, his macular hole peeling, the island peeling technique. How he manages to do it so beautifully. It's amazing. Really very great. Anyway, nice meeting. Thank you, Mohammed, for the invitation. And I hope you enjoyed my presentation also. Thank you all.
Thanks. And Dr. Ayman.
Thank you. I want first to congratulate you, Mohammed, for just beautiful meeting. It's really very nice. I enjoyed it very much. Thank you for inviting me to be a participant so I could meet some of my old friends. I haven't seen them for quite some time, and I haven't seen you also for quite some time. So I really thrilled. I'm very happy to meet all of you. Thank you very much for giving me this opportunity, and I wish you all the best.
Dr. Rashid.
Thank you, Dr. Mohammed. Actually, this was a great chance for us to learn how to make conferences, not only to learn knowledge.
Thank you very much.
And we don't have that enough knowledge like you. Thank you very much for this. I was thinking all the time how to make our next conference and to copy some ideas from you. Thank you very much. Thank you for a great panel also.
Dr. Ahmed, my dear friend.
Thanks a lot, Dr. Mohammed. Great effort as usual. Every time you never give us any chance for improvement. You are improving every time, each and every conference you are doing, and you are doing great effort. Thanks a lot for the great panel, Dr. Carlos, Dr. Ramzi, Dr. Gilhard, and definitely Dr. Hassan, Dr. Ayman, Dr. Rashid. Thanks a lot, all of you. I learned a lot, as usual, from you all. Thank you very much.
If I want to say something, actually, without your presence, there will be no conference. There will be no success. So the thanks are not for me, thanks for you, for sharing with us your experience, your time. Thanks for everyone who participate with us and make this conference success. I hope it is success. And thanks for everyone here. Thanks Dr. Carlos, Dr. Ramzi. All the times they are never, I'm behind them till they agree to be with us. So insisting, and they cannot run from me. I don't know. I hope they tolerate me. Thanks for Dr. Gridhar to be with us this first time. And we are happy that you are accept. Dr. Gridhar is one of the pioneer in vitreoretinal surgery in India and worldwide. Thanks, Dr. Hassan, Dr. Ayman. I cannot say anything about Dr. Ayman. He is my teacher, and I am happy that will be with us all the time. Dr. Rashid, we are learning from you. You are also pioneer, but you are hiding yourself as usual. And the most thanks actually for my dear friend, Dr. Ahmed. He is one of the supports and helping to arrange so many things, but he is like what we call a soldier that is doing everything without knowing. Nobody knows that he is doing these things. Thanks for all companies, they support us. Thanks for the management event, and thanks for the participant who stay with us, and they are eager to learn from all of us. Thank you, and we hope to see you soon, inshallah. Thank you, and good night.
Hope to see you. Have a good time. Thank you.
Bye-bye, guys.
Bye.
Bye-bye.
Bye-bye. Bye, Carlos.
Night. Bye.
Good night, everybody.
See you, inshallah.